Hi, everyone. I'm Deborah Kahn, founder of Being Patient. Today, we thought we would take a little time to talk about the 7 stages of Alzheimer's. It's really easy to see how the 7 stages are defined, but I find as a daughter of a mom with Alzheimer's, sometimes we're scratching our head saying, I wonder what stage she's in now, and really why that matters. So, we have asked Dr. Zaldy Tan to join us today. He's joining us from Cedars-Sinai in Los Angeles. Thank you so much, Dr. Tan, for joining us.
It's a pleasure, and thank you for the opportunity, Deborah.
So, I remember when my mom was first diagnosed with Alzheimer's, one of the first things I did was kind of look up what the 7 stages are. And really, what I found now that I'm, probably, I don't know, 6 years, 7 years into having a mom with Alzheimer's, what I find is I'm actually still confused about what stage she's actually in. I mean, it's easier to say early, medium, or late. But actually, if you said, is she in 5, 6, 4, 5, 6? Sometimes she's in 4, sometimes she's in 5, sometimes she's in 6. So how do we actually define, or how do we know as caregivers or people who have been diagnosed what stage we're actually in?
Yeah, so I'm glad that you asked this question, because one of the things that I found in my practice is that unlike, for example, with cancer or other progressive chronic diseases, people don't think about dementia as stages, when in fact, any progressive chronic disease should be thought of as stages, because it really allows us to monitor the symptoms, plan for the future, and for those of us health professionals, help educate families of what to expect next. And I think that is truly important. There are many scales for the different stages of dementia, but for the general caregiver or family members, I really want to really simplify it to thinking of it as a continuum, right? So the disease doesn't really have stages in say, because there's a lot of overlap. But the way to conceptualize it, and I think it's very helpful, is to think of it from the perspective of symptoms, common symptoms, and functional deficits that can occur in that stage. And I think this will help the patients and their caregivers to also anticipate the things that they can do, and they can do well, safely, effectively, and they should be allowed to do. And there are things that may not be as safe anymore, and therefore they would need to have additional help and assistance. So, of course, the simplest way to think about it is early, middle, late. Some people say mild, moderate, severe, but I try to avoid that, because when you say you have severe dementia, typically, it's a bit disconcerting, when in reality, some people in the late stage don't have severe symptoms. They don't have severe psychosocial issues. So I'd like to think of it as early, mid stage, and late stage, as we put it. And each stage is characterized by different things.
Well, and I think what's so tricky is that often the lines are blurred. So take hallucinations, for example. I mean, in some cases, they come earlier than in others. But when we're talking about just Alzheimer's disease, not Lewy, not to be confused with, Lewy body, which has earlier symptoms of hallucinations. But, when we say hallucinations are present, are we talking really about a middle to later stage there? Or can you see, with all straight Alzheimer's, can you see hallucinations early on?
Yeah, so that's interesting, because hallucinations at baseline, meaning someone is not acutely ill, someone has not just been given a medication that can induce hallucinations. If that's the case, hallucinations really are not expected till perhaps the late middle stage of Alzheimer's disease. As you mentioned, other forms of dementia like Lewy body dementia can have visual hallucinations even in the early stage of the disease. But with typical Alzheimer's disease, you don't really expect to see hallucinations till the late middle stage, and then, of course, the late stage. The same thing goes with personality changes. There are certain types of dementia like frontotemporal dementia, where oftentimes that is the presenting symptom. The patients will not come to you with memory se, because relative to the behavioral or personality change, it may not be as severe, right? So, but in Alzheimer's, typical Alzheimer's disease, you don't expect personality stage till the middle stages of dementia, which is again very different from the temporal.
Let me just ask you this. Why is it important for us to know what stage a person is in? So, for example, why is it important for my family to know exactly what stage my mom is in, or is it not?
It's extremely important from a research standpoint. For those of us who are doing research, as you know, clinical trials are aimed specifically at a specific stage of dementia. So a lot of the prevention trials are targeting either MCI stage or very early dementia. So just knowing what cutting edge treatments or research or clinical trials your loved one might be eligible for, it's important to know what stage they're in order to participate in the scientific process and discovery. From a practical standpoint, there are characteristics of each stage that will allow one to anticipate the things that they will need and the things that that they should be left to do on their own. A good example would be driving, right? If you think of dementia, it'd be like driving, stop, take away the car keys. That's generally a good rule, but I can tell you that I have some patients with mild dementia who we reported to the DMV, Department of Public Health, and they got called in for their examination, and they passed. And these people have mild dementia, and they're still able to drive, short distances in good weather, daytime kind of thing. So that's a good example of some things that may be very important to the patient, but you don't want to take it away if they're still able to do it safely, albeit you have to monitor it. So as much as we want to anticipate what the patient will need, we also want to know what they can still do for themselves so that we can allow them as much independence and stage appropriate, ability to do things on their own in their own terms. So I think that's a very practical reason why you would like to know what
that definitely makes sense. And we have a question saying, leaving comorbidities out, why do some people progress at different speeds through the stages than others? So why, some people maybe have a rapid decline and others it not so rapid?
Yeah, so I really see that frequently in people who have vascular dementia, for example. Like when patients ask me how long, doc, before this progresses to the next stage, I'll be like, well, it depends, when the next stroke happens. And in fact, we know that a lot of people with so-called Alzheimer's disease, they actually have mixed dementia. So it's not just the neurofibrillary tangles and the amyloid plaques that's causing the nerve cells to die, but a lot of them have small strokes that that they can cause a change pretty abruptly. But if it's pure Alzheimer's disease, you don't really expect like these abrupt changes. In fact, one of the characteristic symptoms of Alzheimer's disease is this slow, smoldering progression where when you ask someone, when did they start getting lost? It'd be like, I don't know, it could be 5 months or 2 years ago, so it's very, very subtle. But with mixed dementia, it's different, right?
So vascular dementia actually progresses more rapidly, is that right, than straight Alzheimer's?
It depends on the type of dementia. For example, people with cerebral amyloid angiopathy, right, which is a form of vascular dementia, they can progress more rapidly. But this is the place where if you have vascular dementia or if you have a mixed dementia where it's Alzheimer's, this is where we can actually do a bit more interventions regarding slowing the progression by controlling cardiovascular risk factors, preventing stroke, putting them on antiplatelet. So that's just one reason. The other thing I want to bring up is that hospitalizations are bad for people with dementia. So if you have someone with mild dementia and they get an infection or other reason, or they get a hip fracture, God forbid, and they end up in hospital, then it's shown that once they get out of the hospital, they may not be as able to get back to their previous baseline. So that's another reason why someone will progress more rapidly than expected.
Yeah, it's it is a bit like solving a mystery, isn't it? It's just you hear so many different cases and different experiences. And, to be honest, I always kind of thought my mom might have vascular dementia because she wasn't progressing in a way that I thought what I knew of Alzheimer's. But I don't say that with any scientific knowledge behind it, So in some ways, I guess we're looking emotionally to prepare ourselves. Like, how rapid is that decline going to be? Do you find that a lot with your patients?
I do, because but certainly caregivers like yourself are looking out for their loved one so that they could be, physically, practically, financially, emotionally prepared for what's to come next. But also, we have to understand that the person with dementia themselves are also going through their own journey. In fact, people with early dementia, I find, can become socially isolated if without the support of the caregiver and their loved ones. They have, for example, they have many friends. Some of the closest one may not be able to deal with the dementia and not be able to adjust to it, and some people may. In fact, in the early stages of dementia, you can anticipate that you're going to lose some friends. And when you get to the middle stage, even more so. So definitely, that anticipatory need for what's come next is very, very important.
So let me ask you about the really early stage, because there's a ton of confusion over this. And actually, most people are diagnosed with MCI, mild cognitive impairment, right? They're not told, like, the first neurologist or doctor's visit, you're not usually like, you did terribly on your MoCA test, you have Alzheimer's. It's usually a sign, they'll say, of mild cognitive impairment. So I've always wondered this. What is it that makes that leap to say it's mild cognitive impairment versus, now you have Alzheimer's? How do doctors determine that?
Yeah, so MCI, or mild cognitive impairment, is its own entity, its own diagnosis. There is a set of diagnostic criteria for MCI, and within MCI, or mild cognitive impairment, there's amnestic MCI, non-amnestic MCI. In theory, it's separate from Alzheimer's disease because people with MCI, by definition, do not have Alzheimer's disease. If you look at the DSM-5 criteria for Alzheimer's disease and other form of dementia, they need to show or demonstrate that they have had a decline in occupational and social functioning. And by definition, people who have MCI do not have that. So they may have memory impairment, both objective and subjective. But when you ask about how they are carrying on their usual activities, keeping their appointments, taking their medication, paying their bills, their social activities, they're pretty intact. In fact, if there's a decline in any of those, then in theory, they do not qualify for diagnosis of mild cognitive impairment. And not all MCI progress to dementia or Alzheimer's disease, which is another interesting thing. So, in a sense, MCI is thought to be a precursor or pre-dementia, but certainly not all of them progress, and it's distinct as an entity from Alzheimer's disease.
So this is a great question that's come in saying, have you seen any patterns in patients that have given clues, or are there any blood tests, brain scans, anything like that can give any predictable clues as to how someone will advance through the stages? So not diagnosis, but, are there any clearer markers out there that you're looking for as a doctor that's going to say someone's going to progress faster than others?
Not at the outset, meaning there are now biomarkers, as you know, both in the cerebrospinal fluid and now developing in the plasma biomarkers. I haven't seen any good studies that show that, for example, like if your amyloid beta levels or p-tau 217 is higher, then you are going to progress more faster. But the interesting thing about biomarkers, speaking of biomarkers, is that now that we have these, monoclonal antibodies, these prevention trials or disease-modifying therapies, I predict that these biomarkers will be really helpful in terms of predicting who is responding to the treatment. I mean, until recently, all we had are their performance in cognitive evaluations and and functional measures. But if we have a reliable way of measuring the biology of disease, for example, neurofilament light (NFL) is one of the biomarkers that has shown promise in monitoring the progression of the neurodegeneration. So I predict that will be a future thing where you can go to your doctor and they will draw blood or get a CSF and saying, your level of this biomarker is stabilized and therefore we're in good shape. And while if it's increasing, you might be like, I think we have to do something else.
So I think I have the most conversations about different stages of Alzheimer's with people who have a loved one who are reaching a later stage. And the reason behind this is because I believe people want to know, although they don't put it this way, but how close are we to the end, right? And so for example, you start to see somebody who has really bad memory loss, like they stop recognizing their loved ones. They can't recognize family members anymore. They're losing vocabulary. But yet they can still dress themselves or take a shower or something like that. So there's a lot of confusion in that area as to really what stipulates you're reaching the end. Is there a way to define that? I mean, it's kind of a hard question to ask, but I've often thought of it myself.
Yeah, and I understand why that's a source of confusion for people, because these stages overlap. So, for example, ambulation, for example, right? If you think about the typical trajectory of dementia, they will be, walking is not affected. Alzheimer's disease specifically, walking is not affected in mild disease. They walk around. They could walk 2, 3, 4 miles a day, and even in the early stage, they can even do that themselves without getting lost. And once you get to the moderate stage, they could still walk, but it could be a bit slower, and they could wander and they get lost, hopelessly lost, even though physically they're still able to ambulate. But when you get to the late stage, typically what will happen is that you will get people who are really getting slow. They can fall. In fact, a lot of head trauma can happen during that period. And then you get to the late stage. What happens is that they become wheelchair bound or bed bound even, and they can get pressure sores from being on their backs for most of the day. So that's the typical progression. However, there are people who don't progress that way, meaning they're ambulatory till the very end, right? And what may get them in the end maybe is aspiration pneumonia or something else altogether. So it's very difficult to say that, it's not like the developmental milestones that you see in children, for example, for those who are, for those who have children, the pediatrician will say, okay, this is by this many weeks or months that child should be able to turn on its back or turn to its belly or stand up.
Right.
It's not that way. But the interesting thing is that one of the things that I help my patient understand in terms of that question is when is my mom or dad going to lose their ability to swallow or their ability to walk? I say roughly think about the order that an infant gets these abilities, right? So an infant is born with ability to swallow, like milk, but it can't talk, right? And it can't walk. It can't do, calculations or reasoning. So if you think about it, those come in later. So those are the first one generally to get lost. So the swallowing, in my experience, is one of the last ones to go. So once they get aspiration pneumonias or dysphagia, causing aspiration pneumonia, and some of them, are being offered a gastrostomy tube or a D tube. That's why we do not recommend it, because typically that's not the problem. The problem is that they're already in the last stages of the dementia, and therefore inserting a gastrostomy tube and giving them artificial feeding is not going to change the overall course of the disease.
Dr. Tan, how, we're usually, when we first have someone with Alzheimer's in the family, the first thing you do is how long will this person live with the disease? And typically, it's maybe 6 to 10 year range. However, there are many stories out there of people who have lived for 2 decades with neurodegeneration, and which doesn't surprise me because on Being Patient, we interview a lot of people with dementia who have had, a diagnosis for 5 years plus and who are very still intellectually intact, right? They still can perform at a high intellectual level. But my question is really, are you seeing a pattern of how long this disease lasts? I mean, we have an average kind of, but what's your experience as a doctor?
I can tell you some patterns that I observe. When we say, 5 years, 8 years, 10 years, it's from the point of diagnosis, right? But that there are people who get diagnosed really early because they are just hyper aware. Maybe they have a family history and they're already hyper vigilant of their own thinking. And I will just show up and I'm going to get neuropsychology testing every year to know exactly when I get it. So that obviously those people will have a longer life expectancy from the time of diagnosis than for someone who come in relatively late in the pathology of the disease. And therefore then the perception is that, oh my God, he progressed so fast. He came from the diagnosis, by 4 years, he was gone. But in reality, maybe we didn't really catch that person early enough to have that 5, 8, 10 years. In fact, one pattern that I've seen is that people who are highly educated tend to present later, except if they know that they have a family history or something like that. And the reason is because they usually have a lot more social resources. They also have a lot of cognitive resources to kind of cover up the memory loss. And they also have a lot of pride in their intellect. So they come in later. So it's a perception that they progress faster, but in reality, they're just coming in later in the course of the disease.
What about genetics? Do we know, like, let's say if somebody is a carrier of the APOE4 variant, either having 1 or 2 copies, is there any indication that progression will be different than those who don't have the Alzheimer's gene? What's called the Alzheimer's gene, I should say.
Not to my knowledge, there hasn't been a good study that look at the rate of progression. It's a risk factor, as you know, getting if you have 2 copies of APOE4 allele, but they don't necessarily will progress faster. The progression really is dependent on a lot of other factors, like I mentioned, your vascular burden, so to speak, and the other medications and other things that can affect the progression itself.
So I always ask these questions when we have doctors such as yourself on. What are the type of questions we as people with loved ones with dementia or people who have been diagnosed, what should we be asking our doctors to really get the best information and care, especially in particular to the 7 stages as defined, by the medical community?
I think a good conversation that all of us should be having, caregivers, patients, and physicians and health professionals alike is a very simple: what stage of dementia am I in, right? Or my father is in? Is it mild? To keep it simple, is it early, late, or mid stage? And not having that conversation means that we are just thinking of dementia being a monolithic yes or no, but in reality, it isn't. I mean, you wouldn't go to any oncologist who didn't say what stage of cancer you're in, right? Because it leads to another discussion of what's to come next and what needs to happen. I think caregivers need to be very specific with the doctors about what they have observed, because, like I said, the stages are very much symptom-based and function-based. So if you say, okay, doctor, since our last visit 6 months ago, I've now observed that my mother is getting lost now, whereas she used to be walking around the neighborhood, no problem. Now that she's getting lost, sometimes it would be freezing out and she would be wearing shorts. So that tells me that this person has progressed from mild to moderate, right? Because the 2 examples I gave you are symptoms more of moderate stage. And then that will then initiate conversations about what treatments are appropriate. For example, Memantine or Namenda is not FDA approved for mild dementia. It's not. It's only effective and approved for moderate to late stage dementia. So just having that simple conversation will clue in the physician that, I think we just progressed from mild to moderate stage. Let me add in memantine to see if this will be an appropriate add-on therapy to the donepezil, let's say.
How good are cognitive tests in predicting what stage you may be in?
Well, that is generally, especially in research trials and in clinical trials, that is what we based it on, right? Because this is we need some measure of objectivity in the progression. So is it helpful? Yes, it is. Because whenever I see someone, let's say every 6 months or every year, I would do a standardized cognitive test, whether it be a MoCA or a short blessed test. And I will look at their previous performance, and I write in detail what items they missed and how they did now compared to previous, because that will help me determine if I'm seeing objective signs of evidence. But I also ask specifically for subjective signs of progression. Like I mentioned, what are the things that they were able to do 6 months ago or a year ago that they're not able to do now? So those are things I would like. I would put those these pieces of information together, these data points, and then come up with a diagnosis of the stage of dementia, and then have an appropriate conversation based on the stage of the dementia.
So every time, I have to admit, every time at an earlier stage, I don't do it now, but every time I saw my mother, I would give her a MoCA test on my own just because I was curious. And how she performed on that depended a lot on her mood, right? And whether she was tired or, so I've often questioned how good indicators those tests alone are. And so what you're saying makes a lot of sense. You have to kind of put the whole picture together, right? And they're really just one tool. But I have to say, on some days she scored really well, and other days she scored horribly. So to me, like, if you do those enough, then how really accurate are they,
Yeah, so as you know, there are practice effects. If I do it very frequently, then they would get better at that task, but not necessarily mean that they're getting better at the dementia itself. But there's also, good days and bad days, right? So if they didn't sleep well that night, or they just, took a medication, earlier before the exam. So I take that into account. I don't take the score as gospel truth that, they just progressed based on this, or they improved, or they didn't get worse. I think you really have to take into consideration the total picture. And that's why having caregivers like yourself give me an idea of what's happening, just like a blood pressure. If I take a blood pressure and it's elevated, I'm not going to say, you have high blood pressure. I say, why don't you check your blood pressure at home 3 days a week, write it down, blood pressure diary, send it to me, and then we'll make a decision on what happens. It's the same thing with memory. Memory diary will be helpful in terms of informing the clinician of what's going on in the home that may not be seen in the clinic.
Right. I've often thought that our smartphones were the best assessment tools because, on the MoCA test, how they give you a clock and you have to, and my mom, as she progressed, finds that more and more difficult because first of all, it's many layers of information, and where the clock arms are pointing to aren't exactly the exact number, right? So it could be 10 past, whatever. Same thing with a smartphone. There's so many layers to get in and apps to use that I find actually, like, she went from being able to operate her iPhone to just now she couldn't even turn it on, So I often think of that layered approach, like recognizing how many different layers there are, and if you can actually respond to thinking about different layers of thought at one time is a good predictor. But that's just my very amateur sense. I don't know if there's any logic to that.
There is, and that's an astute observation. Certainly, so if you say, heat this food in the microwave, and that means this it's a multiple step process, right? So that's not just memory, that's also executive function, right? Because your executive function tells you to plan and sequence things. So if someone has more frontal dementia and their memory might be fine, they might remember how to take out the food from the microwave and then take out the wrapper, and then but then like, okay, what's the next? How do I operate this? So that's a different cognitive function. And speaking of clocks, the clocks are very interesting. I really like the clock, but at some point it will lose their utility, because the newer generation, millennials certainly, are not so keen with the clocks, right? So that's very much generational. In fact, maybe when the millennials reach the age of dementia, it will be like, here's a smartphone, why don't you make a phone call or do an internet search?
Actually, that's a really interesting point. Like, I wonder if my kids could even, like, you know, draw a clock today. No one really uses clocks anymore, you know, in the way that we grew up using them. So, Dr. Tan, thank you so much. This is really helpful, and it's always so helpful to hear a doctor's perspective and, you know, what you're really anticipating with your patients and sharing the insights with us. So thank you so much for joining us, and I'm sure we may get more questions, which we will redirect to you if other people want to ask questions after this interview is over. But thank you so much for your time.
It's a pleasure, Deborah.
So if you missed any of this interview, or you want to, you know, revert back to parts of it, we always post them on beingpatient.com. Please don't forget to sign up for our newsletter. If you go to our website, beingpatient.com, you'll see a big sign up. Sign up for our newsletter, because within those newsletters, we are always letting you know about upcoming talks. These talks are truly meant for people like you who may have questions and not access to the experts. We're bringing the experts to our platform so you can ask any question you want. So thanks very much for joining us. Don't forget to sign up for our newsletter, and we'll see you next time.